Hello, everyone, and welcome to Clued Up, a free webinar series bringing expert led conversations on cycles, hormones, and health into the open. And I'm really glad you're here today. My name is Eve Lepage, and I'm the Senior Reproductive Health Advisor at Clue, where I focus on translating reproductive health science into tools and information that help people better understand their cycles and advocate for their health. Today, I'm joined by the wonderful Dr. Charis Chambers, who is Chief Medical Officer and an OBGYN. Dr. Chambers has spent many years caring for patients and helping people navigate complex reproductive health concerns. So I'm really excited to have her here to bring her clinical perspective to this conversation. So today we're going to be talking about heavy and painful periods, something that millions of people experience and that is still very often minimized or dismissed. So during this session, we're going to break down this topic together. We're going to talk about the biology of pain, what heavy bleeding actually means medically, and the red flags that warrant investigation, when pain is a signal that something more might be going on, and some of the conditions that can sit beneath these symptoms, like endometriosis, adenomyosis, fibroids, and others. We'll also discuss evidence-based treatment options and how to advocate for yourself in clinical conversations. And towards the end of the session, we'll talk about how tracking your cycle and symptoms can help support conversations with healthcare providers. And we'll leave time for a live Q&A where you'll be able to ask your questions directly. And for those of you attending live today, we also have a couple of special resources to share with you, including a self-advocacy worksheet designed to help you prepare for medical appointments. And if you'd like to revisit anything we discussed today, this session is being recorded, so you'll be able to watch it again or share it with someone you might find it helpful. So before we dive in, Dr. Charis, I'd like to give you a moment to introduce yourself and tell everyone a bit about your background and the work that you do.
Hi, Eve. Thank you so much for having me. And hello to all of you who have joined today. I'm so excited to discuss heavy and painful periods. This is something that I see a ton in my clinical practice. My background is that I'm a board certified OBGYN and I practice clinically, actually taking care of teens and adolescents and young adults and even children with periods. And so the diagnosis of heavy and painful periods is really important to me because these younger folks are entering into having periods for the first time and they often don't have an established limit of when things go from normal to abnormal. And in my clinical experience, I've also seen that their parents don't either, because we don't always know if this is just something that everyone in my family has. Maybe everyone in my family has heavy periods, and so we just normalize it. Or everyone in my family has endometriosis, and so we just normalize painful periods. And so I'm really hopeful that we'll be able to bring some medical accuracy to the conversation and give you the tools to differentiate between what is normal, what is abnormal, and how to advocate for yourself when you go to your doctor. So, again, this is my favorite topic probably to talk about, not just because I know how real it is, but I know how helpful it is to get validation and understanding about your bodies.
Thank you so much, Dr. Charis. So Shars, I want to begin with something we see again and again in reproductive health conversations. Many people grow up hearing that severe cramps or heavy bleeding are just simply part of having a period, something you're expected to tolerate or push through. Why do you think heavy and painful periods are still so often minimized or dismissed?
I think the better side, or my hopeful, optimistic version of my brain, hopes that it's mostly due to lack of education, right? That people have just been told, especially for generations, this is just what you're going to have to deal with. And many people, if they felt like there was no opportunity to improve something, it's like, why bring it up? Why must I dwell on this? Why would I talk about it if I don't have an option for improvement? If this is just normal, then I'm not going to bring it up as much. And so for some people, from a generational standpoint, their grandmother brought up heavy bleeding and was told by her mother that she just has to live with it. So then she told her daughter, who is like the person who's experiencing it, their mother. And so that perpetuation can be directly related to a lack of education and someone just saying, this is normal, this is the cross that you must bear, this is what it takes to be a woman, and that being the normalization of it. So it's being dismissed, not because people mean you harm, but because they don't have the tools or the education to know better, for lack of a better term. There's also the more like sinister side of things where there's more of a view where if it happens to women, we don't care. That if it's about the
Mm.
reproductive health system and it has anything to do with the uterus or the ovaries, then this is just something that we don't touch. It's just something that I don't care about or don't want to talk about. It's icky. It's gross. This is a land of whatever your issue is, that stays in that taboo land that we don't talk about. And I think that's where the stigma and shame and even patriarchy is felt. And all of it hurts, all of it harms, even if the intent isn't to harm. So the origins of stigma and shame are plentiful. They come from religion and communities and cultures and people that do not intend to always harm you, but the outcome is still harm.
Yeah, and I think that's really important to clarify that it's not always intentional, and
No.
sometimes that trauma is generational, right? And yeah, and so you spoke a little bit about it, like generationally,
Mhm.
culturally. How about medically? How do you think this normalization contributes to things like delayed diagnoses?
Yes. So there's also a lot of physicians, unfortunately, who are trained in older times or just trained in systems and in schools or programs where this wasn't taught or it wasn't emphasized or it wasn't valued. And so those folks are more likely to dismiss your pain. If you see me, I'm sitting here like, man, that sounds awful. Oh my gosh, I know how real this is. Partly because I experience period pain myself, but there's also the element of how I was trained as an OBGYN, as someone who pursued subspecialty training, as someone who reads about this with a genuine interest. And so there is some failure in significant failure in the medical system as relates to training providers to care about this. The other aspect is pain is invisible, right? It's not something that I can see or meaningfully measure with a test. And so those things that require more conversation, more belief, more compassion, they take longer. They are not typically reimbursed or even valued from like an insurance standpoint as much. And so when people are thinking about the business of medicine, this doesn't fuel that business, and I hate to highlight that, but I think it's worth validating that if I talk to someone about their chronic pain to really understand it, that's going to take 30 to 45 minutes. Your insurance is going to say, I should have done that in 10, but you needed to tell me how your whole life was affected. I needed to hold your hand and hold space with you because it is an emotional burden that you have been carrying. And so the compassion and understanding and time that it takes is also not valued by our like capitalist, business focused medical system. And that is a problem that is on the hospital and medicine side and not on the patient side.
I remember when I was an undergrad and I was taking a pain class. So it was actually a psychology of pain, and I
Hmm.
remember the professor saying that you would be surprised how few medical students actually learn just about pain, like have classes just on pain.
Hmm.
And then when you couple that with just the lack of female representation historically in research, just in general, you have, women who are experiencing pain, and we just do not have enough answers for that, and not enough training for that.
Yes, I remember in training working with a doctor, I believe he was a trauma surgeon. And again, when you're thinking about these people and what they're trained to do, as a trauma surgeon, you are trained to save lives. If the patient lived, you were successful. And so the measure of success varies depending on your personal focus as a provider. And I remember this trauma doctor telling me no one has ever died from pain. And what he was trying to say was just because a patient was in pain, that wasn't his focus. It's not that I mean, kind of didn't care about it. He's like, are they alive? Did I save their life?
Yeah,
And I remember being like, I guess no one has ever died from pain, but struggling with, well, have they not? Because I think if
yeah.
someone had chronic pain, that could increase depressive episodes that could make someone want to unalive themselves. That is a real thing. And so maybe people have died from the consequences of pain, but maybe you never recognized it because you're a trauma surgeon and your whole focus is, did I get them out of the door? Did I do
Did I
my
stop the bleeding?
Exactly. And I remember
Yeah,
being like, but that's some people are trained by that.
yeah,
And if that is
yeah.
if that's the mantra that you carry as a provider, you are not taught to value or treat or meaningfully consider pain.
Yeah, that is very true. I think if we really want to move past the idea that these severe symptoms are just part of having a period, it
Mhm.
helps to understand what's actually happening in the body
Yes.
during menstruation.
Yes.
Um, Dr. Sharas, could you walk us through a little bit about the biology of period pain? Like, what is
Yeah.
actually happening in the body when someone is experiencing menstrual related pain?
So I conveniently have my little uterus set up behind me, which is like one of my favorite backdrops in general. But I want to talk about pain in two separate ways because when we talk about pain and the way I was taught, we call it dysmenorrhea. I mean, that's just so you know if you ever see the diagnosis in your chart, but that's like period pain. There can be primary period pain, which means, hey, it's just a part of what your body does as a result of physiology, and it's still affecting you, but the source isn't some abnormal underlying cause. And then there's secondary period pain, which makes me think of like our fibroids and endometriosis and those sorts of things. So primary period pain is basically when your body starts to shed this uterine lining here, when the signal of hormones drops, so your progesterone level drops to trigger the shedding of this lining, the lining releases inflammatory markers. We call them prostaglandins. And that inflammatory process triggers cramping and pain to shed this lining and to promote change. And so I tell my young patients, when you touch your hand on a stove and it starts to throb and it turns red, that is inflammation. Inflammation is swelling and pain and all of these things and recruitment of blood cells to an area to create change. And so this is like physiologic or normal change. It's almost like a demolition process. Like if you're demoing your house to change things, it's not like your house got burned down or there was something tragic that happened. It was a part of the normal process, but things still get broken. There's still damage. And so it's controlled damage from the uterine lining. It causes there to be contractions and discomfort. And because the uterus has neighbors, it can affect those neighbors as well. That is primary pain. I'm not saying that pain is normal. I'm saying the release of inflammatory markers that causes cramping and contraction and shedding and all of those things, that is normal and that is a normal process. Normal pain or pain that doesn't have an underlying cause still deserves consideration and treatment. Okay, secondary pain or secondary dysmenorrhea, that may be due to like endometriosis or fibroids, which means there's abnormalities that are found around the uterus or in the pelvis or within the muscle wall that cause there to be greater discomfort because of a lack of space, because of pressure, or because of increased bleeding and scarring and inflammation that worsens this pain beyond just that primary level. So there's true reasons behind why pain is occurring that also is suggestive of and supportive of why anti-inflammatory medicine tends to work better than like your non-anti-inflammatory medicine like acetaminophen, paracetamol, for example. Your ibuprofens tend to be a little bit more effective because they are anti-inflammatory. They are affecting the inflammatory process that is almost always a part of the pain picture. I know that was a lot, but pain can be complex.
And we're definitely, I want to talk more about the different types of treatment options because I think that's
Yes.
super important, and we will get to that. But this process that you're explaining, it's rarely just felt isolated into the
Right.
uterus, right? Like we when you think of period pain, it can really radiate to the back, to the legs,
Yes.
and it could even cause GI symptoms like
Yes.
nausea and diarrhea. Can you tell us a little bit about why that is?
Absolutely. And so it's fascinating because my patients, especially my younger patients, they're like, why is my poop so different on my period? And they're like whispering. I'm like, girl, let me just tell you, like, absolutely. So the reason that happens is when you think about your body, if you turn to the side, for example, anteriorly or in front of your uterus is the bladder. That's what holds the urine. That's where you pee from. In the middle is the vagina connecting to the uterus. Just behind that is the rectum. That's where your poop is. That's where you poop from. And then your intestines are all there too. So all of this stuff is within the abdominal pelvic area, within the abdomen and in the pelvis. This is just a room. It doesn't have, walls or any separations. Everything is near each other. So when you have inflammation at your uterus, that inflammation can affect your bladder. It can also affect your intestines. And inflammation kind of almost gives like an inflammatory bowel-like picture where you can have diarrhea. It can be more watery. It can have a worsened smell. It can be associated with worsening abdominal cramping. So all of those things are related. We also see folks that have endometriosis, that have endometriotic lesions on the bladder, having painful urination or painful bowel movements, all of those things. And so when I hear a patient describe pain, that's pain at the uterus and then involves like GI symptoms and even bladder symptoms, I'm like, man, this might be endometriosis, or this is something that makes sense in my mind and deserves treatment.
Right. And how important do you think it is to think about the whole cycle when you're thinking about pain rather than just the bleeding days?
Right. So when we think about period pain, we almost think that we have to be on our period to experience that pain, and that's how they correlate. There's so much pain that can occur during the fullness of the menstrual cycle, and highlight that intentionally because the menstrual cycle, because it is a circle, is continuous. You are not always bleeding, but you are always on your menstrual cycle. Menstruation or your period is just a portion of that cycle. So even with the normal primary dysmenorrhea that we categorize as period pain, we can have pain that starts before bleeding starts. That's like our warning cramps. And I always tell my
Mhm.
patients, pay attention to your warning cramps. That's your signal because it doesn't have to be associated with bleeding for it to be real. There's also mid-cycle pain that can be associated with ovulation. That pain is associated with stretching of the ovarian kind of tissue and even rupture of that cyst or follicle to release that egg. Ovulation is normal, but it can still be painful. And we certainly know with endometriosis that there is acyclic pain or pain that doesn't match a correlative time in your cycle that can feel like it doesn't correlate to anything. That is strongly associated with endometriosis. So it's not enough to only ask about what your pain looks like when you are bleeding. We need to be asking about pain throughout the entire menstrual cycle.
And so going on that, a lot of people are told that like these cramps are just normal, but there is a little bit of a difference between discomfort and
Right.
pain that disrupts your ability to function.
Yes.
How do you how do you distinguish between that expected menstrual
Mhm.
discomfort and the pain that needs investigation?
Yeah, so it's so fun to talk to like the youngest people who are new to periods about this because they're like, I mean, when do I actually care? And I'm like, well, that's the point. When do you actually like it really is dictated by you. So I
Mhm.
say, well, what are you able to do with your cramps? And like, oh, anything. I can go to school, I can play with my friends, I can take a nap, I can read my book. I don't feel compelled to treat it. Or it stops me in my tracks. I must lay down. I can do nothing. I cancel all
Mhm.
my plans. And there's even a spectrum between that. Maybe like I can show up to my softball game, but man, if I have to pitch, I don't feel comfortable doing it. Or if I have to do like a debate team, I don't give my best performance. There's a the level of how it affects your life, but if it affects your life and the extent to which it affects it determines is it just discomfort or is it pain? But that's with all things. I think the real takeaway is that it is determined by you and your goals for your life. It cannot be told
Mhm.
by anyone else. I can't say that, oh, that's just discomfort or that's not important enough. How strongly does it affect you? Do you feel compelled to use medicine? Another thing is when patients are like, asking if someone took medicine is not good enough, right? Because some patients are like, I just don't want to take medicine, or I don't feel good about it, or my mom doesn't let me
Mhm.
take it. And so it's like, if I offered you medicine and there was no barrier to it and you weren't going to disappoint anyone, would you take it for this? And if they say yes, the strong likelihood is that we've left just discomfort and we're inching closer to something that's actually more serious. Now, if it responds to over-the-counter pain medicine or small interventions like heat therapy or taking a bath or even going for a run or yoga, then maybe that's in the land of not like clinically concerning, but still something that deserves consideration and understanding.
Mhm. Mhm.
Yeah.
Yeah, and it helps to know what are some of these things that you can help with that kind of pain too. Like you mentioned, you talked about people avoiding PE and gym class and things like that, but actually, some movement can actually really help with that kind of period pain, and seems like a bit counterintuitive for some people, but
Oh my God.
movement, even like low intensity exercise, yoga has actually been shown to
Yes.
be very beneficial for period pain as
Right.
well. Mhm.
And when I tell my patients this, they almost look at me like, "Are you kidding?" Like that is the last thing I want to do. And I tell them the story of me being in high school and starting my period literally as we were getting on the bus to go to cheer camp for the next like 5 days.
Mm,
And I was like, "This is
mm,
awful. How could this happen to me? Why am I cursed?" But it was my best period ever because I was moving constantly. That actually works well for folks who have that kind of discomfort to mild period pain. I am not suggesting someone with severe debilitating endometriosis related period pain goes to work
mhm.
out and expects meaningful improvement. While it may
Yeah.
improve your mental health and your ability to just kind of get to moving a little bit, we are not suggesting that it is the true alternative to
Mhm,
meaningful care or interventions in medicine or any of those things. But it has been proven to help with mild period pain to moderate period pain.
mhm, mhm. And I think it's important to say when when it comes to making that distinction between that normal, mild period pain and something that is more debilitating and having an impact on your daily life, it's really like you said, that is subjective. It is your experience. Like you do not need to justify that to anyone. If your pain is impacting your daily life, it's enough to say, because I say it is,
Yes,
right?
and that is an added layer to people with period pain. The need to constantly campaign and
Yeah,
prove it, like you're some sort of attorney doing some closing
yeah.
argument. You feel like you have to, this burden of proof is on you in addition to dealing with the pain. That's so wildly unfair. And so, one of the things that I tell my patients before I even offer them the imaging studies that I want to do, I'm going to order an imaging study, but even if that test comes back normal, I know you still have pain. I still believe you have pain, and I'm still going to do everything in my power to treat that pain. I'm ordering this not to prove you have pain, but to see
Yeah.
if I can identify a cause. So even if providers can just say, I believe you, that is a
Yeah.
meaningful change to forcing your patient to create this whole burden of proof type of argument so that they prove to you that they have pain. That's unfair. And it's another burden that these patients don't need to carry.
And that's something I always say is that nobody knows your body better than you.
Right?
You are
Right.
your own expert in your own body and your own pain and your own experiences. And
Yes.
so, yeah, you shouldn't have to justify your own experiences to anyone else. And on that note, I want to talk a little bit about heavy bleeding because
Yes.
I know that there's been a lot of changes in the medical world
Yeah.
in the last several years, and there used to be when we were talking about heavy menstrual bleeding, there used to be this like cutoff of 80 mLs. That's what you used to
Right.
see in all of the textbooks. You have heavy menstrual bleeding if you are bleeding more than 80 mLs per period. And one, I don't know how you are
Who
measuring your
knows how to do
period
that?
blood, right?
Right.
Right, because there's like other stuff in there too, and it's not
So much.
just blood, right? And it's very difficult to one actually measure that, and then two, it touches nothing on the actual experience of having
Correct.
heavy menstrual bleeding. Can you tell us a little bit? One of the biggest questions people have is how heavy is too heavy, and what do you say to that?
Yes. Oh, I love that you brought up that distinction because some years ago, and I think even when I was in training, the cutoff was that 80 mLs. And you're like, what even is that? I didn't really understand mLs and volume until I started actually breastfeeding my child, like as a whole doctor. Like, what do you even mean, right? So it's
Yeah.
hard to ask for people to understand that, especially when it's being absorbed into a period product like a tampon or pad or period underwear. Like, how can I quantify that? If I used a period cup, maybe, or a period disc, sure, maybe I could somehow eyeball it, but otherwise, that's not reasonable. So I'm very happy that we shifted away from that quantitative amount to a qualitative picture. How does it affect you? Does it affect you emotionally, physically, socially, professionally? If it affects your life in any meaningful sense and you say it's too much, it's too much. It's my favorite. And I love telling my patients that because they're like, well, I don't know if it's heavy or not. I'm like, well, I can quickly help you determine that. Does it bother you? Does it impact you or limit what you're able to do? And they're like, yes. Like, guess what? That's all I need to know. And I love how validating that is to be able to say, actually, that's all I need. I just need
Yeah.
your endorsement of it, and I believe you, and we work from there. So if you're out here and you're like, I don't know if it's heavy menstrual bleeding, it is more so how it affects your life. So we can always say the normal kind of duration of bleeding should be like 7 days or less. We really don't want you going longer than that, so that can be prolonged, and that's too much. There's a frequency idea that you don't want to bleed too fast, so we don't want you to be changing a menstrual product more often than one per hour for more than 2 hours. That can be like, hey, this is too much bleeding. Um,
Mhm.
and then we typically expect you to use about 3 to 6, tampons or pads throughout the day. If you get beyond that, or you're having to stack products and all of those things, you're constantly bleeding through or passing really large clots, typically clots that are larger than a quarter. Those are signals that heavy menstrual bleeding is taking place. But the only thing that's required is you endorsing that it is bothering you or impacting your life negatively, which is amazing that that's all you really need now. And it's much better than some weird little number of 80 mLs that no one knew how to fully kind of quantify and report.
Exactly. So now all you need to say is, I'm experiencing heavy menstrual bleeding. My period is too heavy, and that's all it takes, really. And
That's
that's
right.
when the investigation should really begin. And
Yes.
when someone comes to you and they say that I have my period is very heavy, it's affecting my daily life, what are the first things that you are looking at? What are you assessing?
Yeah. So whenever I hear that, I look at the patient in front of me. I want to make sure that they don't look like they are exhausted. If they stand up, they
Mhm.
don't look like they're about to pass out. And I look at their vital signs, obviously, to make sure that we don't need to do an urgent intervention. I have seen patients that bleed so much that they need a blood transfusion, like
Yeah.
immediately. They need
Mhm.
immediate intervention or given some sort of fluids or something to regulate their body so that their heart isn't working so hard, so that their organs are functioning appropriately. People don't understand always that the volume of your blood isn't just a nice to have, it is how your body functions. It's how oxygen and nutrients get to all of your
Mhm.
organs. And so, in chronic states of diminished blood volume, we can see anemia and even organ damage. So, it is not some light work. And I try to explain that to my patients too. Like, this really matters. And this is the first thing. I'm going to rule out emergencies first.
Mhm.
Secondarily, I'm going to understand how bad is it? How does it affect you? What are we looking at? What are our goals? And how has that changed? Because that informs like how worried I am. Sometimes I'm worried about a bleeding disorder. Sometimes I'm worried about a structural issue. Sometimes I'm like, hey, this is just on the cusp of heavy bleeding. Maybe we just need to support them. The other thing I try to do is get some imaging studies potentially to make sure we're not missing something. Again, these are rare, but some people are born with abnormalities, especially our younger
Yeah.
patients, like a duplicated uterus. Very, very rare, but I have seen it. I'm
Mhm.
like, hey, you're going to bleed more. Or on older patients, there might be a presence of fibroids or polyps or other structural findings that if we did not look, we would be fighting a battle without knowing our true opponent, for lack of a better term. So that's an aspect of it. The secondary aspect is getting lab work. It seems silly to take blood from someone who's already losing blood, but it's a small amount and it can give us understanding of how bad, off we are. Are we just iron deficient? Are we truly anemic? How can I intervene? And do we need to even use medicine to stop periods for a while? I'll stop periods for a patient for 6 months if their body needs to recover and they don't have the
Yeah.
reserve necessary to tolerate a normal period. And so when I see patients, I'm always ruling out emergencies, getting an understanding of the clinical picture, and then looking for causes and formulating a plan that aligns with my personal clinical goals of getting them to good, standards of health, and then their personal goals of having a good quality of life.
And sometimes when I've heard this often that someone goes in to see a practitioner because they're having fatigue. They think they might
Mhm.
perhaps, be a little bit deficient in their iron, and then they have their hemoglobin checked and everything comes back normal. And then
Mhm.
that's it. That's all. You're on your way. Can you tell us a little bit about what might be missing there?
Yeah. So gosh, so hemoglobin is great, right? The hemoglobin is when we're looking at the actual amount of like red blood cells in your body. Like we take a sample and we say how much of this is red blood cells. It's almost like having a bowl of cereal, and if your red blood cells are Cheerios, like we're looking at how many Cheerios are in this milk, right? And so the relative amount tells us how good things are. That is only part of the picture because your red blood cells are made by the use of iron, and iron actually starts to deplete before that number of red blood cells starts to decrease. And iron depletion or iron deficiency has clinical manifestations. Like yours, actually, people have fatigue and discomfort and headaches. You can have that just from iron deficiency alone. And so, an analogy I like to use, there was a time in which I was actually dating my now husband, and I came to the house and I saw smoke. It was just a small amount of smoke. But I was like, man, that's really strange. Why is there smoke? And so I called the fire department, and it ended up being a very, very small fire. And so, what they told me was, where there's smoke, there's always a fire. If I was looking for actual flames, I would have missed the fire. But smoke is small enough for me to notice that. And so if you start looking for flames, you might miss fires if you're missing like the smaller fires, the earlier fires. And so looking at iron deficiency and actually looking at something like a ferritin level to check whether iron is low will allow you to get those like smoke like smaller fires instead of waiting for there to be full-blown flames, which means you're a little bit late. So I don't want to wait for anemia to present itself when I could intervene earlier with an earlier sign like iron deficiency.
So, what kind of things would you tell someone who's going into an appointment and they're concerned that they may be a little bit low on their reserves? What kind
Yeah.
of blood test should they be asking for?
So I would just say I'm interested in my iron levels, and I think that
Yeah.
that's probably one of the easier ways to say that.
Hmm.
And you would hope that your provider who you're seeing understands that iron deficiency also leads to symptoms. But
Hmm.
again, there's a clinical disconnect in like when we're thinking about urgency of situations, as
Yeah.
long as someone's not anemic, for some clinical provider, they're like, that's my goal. If you go to the emergency room, that might be
Yeah.
their goal to make sure that you don't meet criteria for a transfusion. That's all they're looking for. If you're going to an urgent care or maybe even a family medicine doctor, maybe their goal is like, I need to just make sure that you don't need, iron today or that you're not passing out. But your goal matters. And so your goal can be, I want to make sure that I'm optimized across the board. I want to make sure that I'm not anemic, but I also want to make
Hmm.
sure that I don't have a low iron because I know I could just supplement with iron. And it's unfortunate that you have to
Yeah.
say that, but that's how you advocate for yourself by knowing
Hmm.
that anemia doesn't tell the full picture. You need
Yeah.
studies like a ferritin level to
Mhm.
better understand if your iron stores are adequate or not.
So important. And I think that a lot of people don't realize that it can be before you get to that level where you are actually anemic or need a blood
Yes,
transfusion, iron supplements can help you get back your stores. And
absolutely.
it's as easy as taking a tablet.
Yes.
um,
And one distinction I like to highlight just really quickly, Eve, because I've seen it in my clinical practice. I had a patient that was like, I'm taking the iron, but my bleeding hasn't gotten any better. So iron is helping to replete or replenish your iron stores and improve how you make new red blood cells. It is not a treatment for heavy menstrual
Mhm.
bleeding. It
Yeah.
is a treatment for iron deficiency that is a result of heavy menstrual bleeding. But if we need to
Mhm.
manage the actual bleeding, that takes other methods like hormonal therapies. That's a different thing. And so
Mhm.
I've had patients confuse that because we say, hey, we're going to put you on iron because of your heavy bleeding. And they're like, hey, I'm still bleeding. That bleeding is still just heavy as it was.
Right.
And
Exactly.
that's not what it does.
Just putting like a band-aid on a on a massive issue. Yeah, no, okay, so I again still want to get into a little bit treatments, but I want to talk a little bit about some of these conditions, like what you are actually looking for
Yeah.
when someone presents with heavy bleeding, significant pain. What are you thinking of? Like, what are the possible underlying causes are you looking to I guess rule out?
Yeah, so heavy menstrual bleeding and significant pain in silo, like without a full understanding of the cycle, are really hard to fully evaluate. So I like to say, well, when was your last period? Is this new? When did it start? So, for example, if we have every single period has been painful and heavy, maybe we're looking for a structural cause that reliably affects every single period. If it's like, hey, when I skip periods, I have like heavy painful periods, maybe that's a PCOS picture where this person didn't shed that lining for 3 months and now they're having like a massive period, which is going to be heavier and more painful by virtue of the missed shedding that didn't occur for 3 to 4 months prior to that. Maybe someone is fitting a clinical picture of acyclic period pain as well as pain with bowel movements and pain with urination. And maybe that seems more endometriosis like. Maybe they
So
have,
that's pain that's not coming with the period, right? That's coming at
it
any time in the
correct.
cycle.
It
Yeah.
can be any time with the cycle. It can be with the period as well, but they're like, I
Hmm.
never really get relief. This isn't just a bleeding time issue. That can be like endometriosis. And so that makes me think about things differently. And endometriosis can be tied to heavy bleeding. But we also have to look at the full picture of the patient. Maybe this patient bleeds easily when they cut, or they bruise easily, or they have a history of like really bad nosebleeds that require like cautery. That makes me think maybe
Hmm.
there's a bleeding disorder underlying,
Right.
right? There's so many ways, but you have to look at the full patient, and that's why it's important for patients to fully report like the fullness of their symptoms. Looking at pain and bleeding in silo is not good enough to get the clinical picture. It's like how else are other things affected? Other things I've seen with patients, if they have like Ehlers-Danlos syndrome, which is a connective tissue issue,
Yeah.
they tend to have
Right.
heavier bleeding. Like you wouldn't think
Yeah,
about
you
that,
wouldn't think
but it's
about
there.
that.
Right.
Yeah.
So you need the full history of the patient. How affected are they? Is this a new issue, or is this something that's longstanding? And how have periods changed? That's also why I recommend for all of my patients, as soon as they start having periods, to track your periods. Those changes, those clues, for lack of a better term, those things are hidden in your history, and the patterns help me to do a better job of saying, why is this bleeding heavy and painful? Those clues build a bigger picture, and so we're not missing the diagnosis and having to guess with only painful and heavy periods.
Mhm. Okay. And I want to talk a little bit about some of these conditions. And I think a
Yeah.
lot of people a lot of people ask like, okay, endometriosis, I kind of understand what that is. It's when, the uterine lining, the same kind of tissue grows outside of the uterus and it can kind of grow and next to different organs and cause all of these issues. And like you said, that inflammation that goes everywhere. Um, and then there's also its sister condition, adenomyosis.
Mhm. Yes.
Can you tell me a little bit about like what or how are those connected? Why are they often talked about as sister conditions?
Yeah, I think we don't talk about adenomyosis enough. So, adenomyosis is when basically that lining of the uterus, that endometrial lining and the glands are found within the muscle layer. So, your uterus is a muscle. This is all a muscle, which is why it contracts and cramps, just like any muscle. And so, when the glands are found within the wall of the uterus, it causes worsened bleeding. Blood can actually build up within that myometrial or that muscle area and that muscle tissue, and it causes horrible discomfort. And so it's a sister condition in that these cells, the glands that should not be found in this muscle are found there. Endometriosis is similar. Cells that are similar to that are found where they shouldn't be. And so it's the
Mhm.
shouldn't be of glandular tissue and bleeding and inflammation that create the correlation of those conditions. And some people, many people, sorry about the balloons, um, some people actually tend to have endometriosis and adenomyosis together. And so when we're looking for adenomyosis, we can often see that on an ultrasound, and it can show collection of like blood in the muscle layer where you wouldn't expect it to be. And that's because there's glands there that are bleeding that should not be bleeding there. And it's quite uncomfortable. It's a really significant uh, discomfort. It's a significant condition that is characterized also by heavier bleeding and more painful bleeding for that reason.
Right, right. And when you're trying to, if you think you have might have one of these conditions and you're wanting to get diagnosed, what is like really that first step that a clinician would do to if they want to rule out that condition after they've kind of assessed their pain and
Yeah.
everything?
The first step tends to be an ultrasound. That's just one of our easiest tests. It's minimally invasive. And it's really important to understand that if you do not feel comfortable getting a transvaginal ultrasound, which is like better as in they can see better, you can
Mm,
always opt for an abdominal ultrasound. Like all of the ultrasounds I order are abdominal ultrasounds because I'm working with adolescents and younger patients. And so I
mhm.
look on top of the belly and we can see pretty well. The reason we say that we start there is because it's just easy to do. It gives us clear answers up front and it allows us to rule out things off the bat. Now, just because it's normal, it doesn't mean that you don't have any adenomyosis. Maybe we just didn't see it. And it
Right.
definitely doesn't mean you don't have endometriosis. Ultrasounds are really good at ruling out fibroids, and they're decent at polyps. Typically, sometimes we have to do a more involved ultrasound, which is like a saline infused test where we put fluid in the cavity so we can better see polyps. But my starting point would typically be an imaging study like an ultrasound because it's easy and we get answers pretty quickly.
Mhm. And then you can move on from there to more invasive kind of options to really see what's going on. And you mentioned fibroids and polyps, and I think these are also things that are actually quite common. I
Yes,
don't think people realize that they're actually very, very common. But a lot of people don't really know much about them. Maybe you can tell us a
right.
little bit about what are fibroids, what are polyps, and why
Yeah,
are
so
they
I'll
kind of thought about similarly?
Yeah, so fibroids and polyps are both like structural kind of growths that happen in and around the uterus that aren't supposed to be there that contribute oftentimes, depending on where they are, to worsened period symptoms like bleeding and pain. And so fibroids are formed from the muscle layer. So I mentioned that this is a muscle and that's what the uterus is. Fibroids can be like on the outside, I call them kind of like Mickey Mouse ears. They can be on the outside, we call those subserosal fibroids. They can be within the muscle layer entirely. We call those intramural fibroids. And then the fibroids that grow and kind of push into the endometrial lining, those are called submucosal fibroids. Those tend to be the ones that affect bleeding the most. The ones on the outside tend to be the ones that cause more pressure and push on other structures and things because they're larger and on the outside. And then the ones within the intramural cavity can be the ones that cause more like period related pain because they're taking up so much of that muscle. Fibroids are they're benign growths. They come from like muscle cells entirely, and that's kind of something that we see. Fibroids can occur up to 80 up to 80% of women, my apologies, by the age of 50. And so it's very common, but it's not always symptomatic. They tend to be larger and form earlier and be more symptomatic in people of African American ancestry. So Black women are more likely to have more significant fibroids, and they're one of the more leading causes of hysterectomy in the US. So that's fibroids. Polyps are a bit different. Polyps tend to come from this interior layer, and they tend to kind of form a little outpouching within the cavity of the uterus, and so almost like a little growth within, almost like a teardrop shape, for lack of a better term, and then it bleeds more, and so it is an actual source of increased bleeding. That is what we typically see, more of a bleeding type of characteristic there. You can see that sometimes on ultrasound, but you can see it really good if you put a small camera in through the vagina, in through the cervix. You can see that polyp, and you can actually remove that polyp by doing like minimally invasive type of procedure. So polyps are very different from fibroids. Some fibroids can be managed from an internal approach. By just looking within the uterine cavity, but that would only be the fibroids that affect the uterine cavity, which would be those subserosal fibroids. If your fibroid is out here, you're not going to be able to access it or even see it by looking inside the uterus. So I hope that helps to make that distinction.
Yeah, no, that's very clear. And I think for these, especially for fibroids, they are often, I think it's very important that if you know you have a fibroid and it's causing you pain, heavy menstrual bleeding, discomfort, pressure, um, because these things they're often left alone, right?
Right,
If you think that they're not causing any issues, the clinical management is just to, we'll leave
leave
them
it.
alone, we're not going to do anything. If they're not, like, actually impeding on the uterus, or if you're not trying
Right,
to get pregnant and it's the way, they'll be like, oh, okay. So again, it's another very important, if you're having these symptoms, you're having
right.
pain, you should speak up, because in that case then we can actually go ahead and look at treatment options.
Absolutely. And there's the treatment options that are like, hey, maybe I have fibroids and I'm already needing contraception, and so I'm going to be on this hormonal contraception anyway that helps with both. But if we're looking at someone who has fibroids and cannot or does not verbalize or express any meaningful limitation to their life or symptoms, then you're weighing this risk and benefit of adding a potential medicine or during a procedure without there being a true clinical benefit other than being, okay, we did something to these fibroids, but your life isn't meaningfully changed. And so, as a physician, as a surgeon, I have to make choices clinically that do not cause harm. That's like my responsibility. And so, part of that responsibility is a thoughtful and intentional management of risk and benefits. And so, in order for me to better understand that benefit and make that kind of outweigh the risk, I need you to tell me what you're experiencing and what you hope to benefit from this procedure. And that's how I can justify my clinical decision making.
Great. And so I just want to talk a little bit, because you touched on it before, about um, treatment options. And something you mentioned, which I think a lot of people are surprised to hear, that treatment choice, but also timing, can really make a difference in symptom relief. What are the
Yes.
first line treatments that you typically recommend for period pain?
Yeah, so I mean, I think a lot of people think that physicians, and we're mischaracterized often as being like birth control all the time, right? But certainly with my patient population, with younger patients, I want to be very thoughtful with never exposing them to any risk that would potentially harm them long term without there being an adequate benefit. And so I really like a stepwise approach where we start with the most conservative method first, and then we step it up when there's clinical proof that this isn't quite good enough. And so we can start with, hey, let's try some heat therapy, and we'll do some increased, physical exercise and increased hydration and see if that helps. We'll throw in some NSAIDs, right? I can write for naproxen, where we can dose that as needed during those days of bleeding to see if that helps. And so we step up lifestyle modifications, making sure we're not eating super inflammatory food right before our period, all of those things. And then we can step it up to over-the-counter type pain medicine or prescription level, NSAID therapy. Then we can say, hey, I think we need a little bit more. Let's try a low dose hormonal method. Okay. Then we can step it up even more. I can increase that dose, or we can try another route. Then we eventually can step up to even doing interventions like surgical management of like a laparoscopy or something like that if we feel that that is necessary. And so we do a stepwise approach, never jumping to something that isn't clinically indicated, but that indication is guided by your needs. If you come to me and you've tried all these things, then we're like, hey, maybe we can start here. Or if you're like, I actually need some hormonal contraception, then I'm not going to say, let's wait and try NSAID. No, you need hormonal contraception. So there's multiple benefits to this medicine that we can start today. So I customize it according to the patient, their desires, their medical history, and what they've tried historically, and if that has worked or not.
Right. And when it comes to things like NSAIDs, I think a lot of people also don't realize is that if you're already in a lot of pain, you've
Hmm.
waited too long to take them.
Right. Right.
You're right.
Oh
Like
my
you,
God.
Yeah. Like right when you start to feel pain, start taking it. And it's really going to prevent that pain because it's going to work on the inflammation first.
Yes. And so the way
Mhm.
I explain it to my super young patients, I'm like, hey, as soon as that progesterone starts to drop, that uterine lining gets that signal, say, hey, it's time for us to shed, and the inflammation starts to increase. It peaks at the beginning of the cycle and then starts to go down. If we can start taking the NSAID as soon as we feel our warning cramps or the earliest cramps, then we can keep that peak of inflammation a little bit lower and get it to a place that it's better controlled. The other kind of analogy I use is if you know that it is going to rain for 6 hours, it is very silly for you to take your umbrella with you and only put it up after 3 hours in the rain. You were already soaked. Why did you even bring your umbrella? And so if you've already gotten to the point of extreme pain where you're like crawling to get the NSAID because we've waited too long, we really aren't able to meaningfully change that pain experience unless we start early. So don't get soaked. Don't wait to put up your umbrella. Put it up and leave it up for the maximum duration of time where your pain is the worst. And so what I do is I talk to my patients. We have warning cramps the day before, and we have our pain that worsens into the first 2 days. Then that means I want you to take this NSAID time to cover continually for those 3 days, which means we don't have a meaningful break. We're going to take this every 12 hours for those first 3 days, which is only 6 pills. It's only 6 pills, but
Yeah.
it covers
Mhm.
you from an inflammatory standpoint, keeping things controlled. When
Right.
you wait too late, you are setting yourself up for failure, and catching up on that pain can be really, really challenging.
And it's completely safe to do that every period, every cycle.
Completely. So, depending
Yeah.
on your patient history and things of that
Yeah.
nature. But the
Hmm. Hmm.
majority of people, it is going to be completely safe to do that with every period.
Yeah. Thank you so much for that.
Mhm.
So we're getting close to the end. So the last thing I really wanted to talk about was, and one thing we talk a lot about in reproductive health is just how important patterns are. So when someone comes to you with tracked cycle data, pain timing, bleeding patterns, symptom change, how does that help your clinical assessment?
Oh gosh, it's huge because it informs so much about how I can think about what the differential diagnosis is or what the possible causes are. It also gives me a good clinical picture about what success looks like because if we track it to get to the point of coming in to talk about it, I want to continue that tracking so we have data to see have we improved or not. When I have patients that don't track their period and we start an intervention, sometimes it's hard to tell if that intervention is really working. They're like, well, I don't know. I don't keep up with my periods anyway. I'm like, well, darn. Like, we really need that information to see are we getting closer to success or not? And sometimes those changes are more subtle. Changes, they're more subtle than like an extreme thing. Obviously, we can tell if like pain goes completely away or if bleeding completely, lightens. Yeah. But sometimes it can be very minor. And so, in order to see that progress and know we are going in the right direction, tracking that pattern of that bleeding of your cycle and of your symptoms is so helpful. But it's helpful for you to get diagnosed earlier and for us to shift gears earlier instead of me having to wait until something crazy happens that you actually notice. These subtle things can be identified in your pattern of tracking earlier, and we can make the necessary clinical shifts.
And how can someone advocate for themselves if they feel like their symptoms are being dismissed? Like what advice would you give to someone who's going into an appointment?
Yeah, so if someone feels like their symptoms are being dismissed, I would say a few key things. One of the things is like, I'm so sorry. I'm not sure if you're hearing me. This is my main concern. So redirection is one of the things that I think we all sometimes need, and we need that even when we're listening to our spouses or partners in life, right? We love them, but sometimes our brain goes elsewhere because of our focus or what our desires are in that moment. So redirection saying this is really important to me and this is why I'm here. That can be a really good thing. Another thing can be, hey, I know that you suggested this, but I want to reiterate that I've tried this already and something has to give. Giving a goal for the day. Like before I leave here, I need a plan to improve my bleeding. I need a pain regimen that I can use so that I can show up to work. Like redirecting
Mhm.
like from a goal standpoint, hey,
Yeah.
before anything happens today, I need to do this. And the third and final thing is always a second opinion. I don't know that
Hmm.
this is actually supporting me in the way that I hope to. Is there
Yeah.
someone else that I can see or talk to that also has this clinical expertise or in your field or whatever that you could recommend that might offer me something different? And I think that that might offer me something different is important because people practice according to their disciplines and their beliefs and their values. And sometimes just finding the right provider can transform your clinical experience. So if you're not
Yeah.
being
100%.
reiterate
Mhm,
what you actually need them to hear. Like, you're not hearing me, I'm suffering.
mhm, mhm.
Lead from a goal-based standpoint. Like, I need to be able to go to work and not miss work, 2 days out of every month, and that is my goal. Or ask who else you can talk to, and specifically
Mhm.
ask for someone who may offer something different for your care.
So be prepared, know what questions you want to ask, have your cycle information, your symptoms, what your goals are to get from this appointment. And if you're still not being heard, get a
Hmm.
second opinion, speak to someone
Yeah.
else. Great. So we're nearing the end. So before we wrapped up, I just want to say thank you to Dr. Charis Chambers for sharing her expertise and perspective with us today. And Charis, we really appreciate you taking the time to walk us through the science, the clinical side of the symptoms, and what people should be looking out for. And as
Oh,
we close, I want to leave with one final reflection because these reoccurring symptoms that affect your daily life, they really deserve attention and care, whether
yes.
that is heavy bleeding, severe cramps, fatigue, any other kind of pain. These experiences are meaningful signals from your body and they're worth asking about. And they
Mhm.
are definitely worth investigating. So, my hope from today's conversation is that you leave with a clearer sense of what your body may be experiencing, what symptoms are worth paying attention to, and how to approach these conversations with confidence. So, for those of you who are joining us live today, thank you so much for spending this time with us and for bringing your curiosity. And if you have questions, please put them in the chat. And for anyone watching the recording later, thank you for taking the time to watch and engage with this topic. Conversations like this become more powerful when the information is shared. So if something you heard today resonated with you, consider sharing this session to someone else who might benefit from it. And as we mentioned earlier, we want to leave you with a couple of resources to help carry this conversation forward. This is a self advocacy worksheet designed to help you prepare for medical appointments. It walks you through how to describe your symptoms clearly, things like timing, severity, patterns, how your cycle affects your daily life. So you can walk into your next appointment to be ready to be heard and understood. And you can scan the QR code to download that as well. And also, I will share the recording for this if you haven't had a chance to scan it. Um, You'll also see that there's another QR code because we want to give you 12 months of Clue Plus for free. So Clue Plus gives you access to deeper insights, education, and the tools to track your cycle and symptoms over time, which can be incredibly helpful when you're trying to understand patterns or communicate with a healthcare provider. So tracking these patterns over several cycles can help what feels like a vague experience into clear. It can transform this what feels like a vague experience into clear information that supports better conversations and better care. So thank you everyone for joining us today. And now we're going to stay on for our live Q&A and to start taking some of your questions.
Yay.
Yay. Okay, so let's see what questions we have.
I think we have a bunch.
Yeah, we've got a bunch. Okay. Uh, Is there anything you can do to shrink fibroids and prevent them from growing?
Yeah, so that's such a good question, and there isn't really great literature to recognize one particular route. There's been some studies that show the use of statins actually improves symptoms from fibroids. There's a medication called Lupron, which is like a GnRH agonist. Or sorry, we have GnRH agonists and antagonists, Lupron and Erlissa, who that can help with kind of fibroid pain, and they have been shown to shrink fibroids temporarily over time. There's also procedures that we can use that actually shrink fibroids, like uterine artery embolization, and even embolization that we do at time of surgery that's like minimally invasive. So there's a lot of different ways, but there isn't one over the counter or herbal supplement or kind of lifestyle modification that reliably decreases fibroid size. We do see that fibroid size is decreased relative to vitamin D level. So there isn't like a great study that shows that increasing vitamin D intake decreases fibroid size, but fibroids are smaller in people with higher vitamin D levels. So that's one school of thought. And then people that have BMIs that are closer to more standard BMIs and less in the overweight and obese kind of lane tend to have larger fibroids. And so some of those standards would be suggestive of lifestyle modifications of maintaining a normal BMI or a healthy BMI, according to your size and age, and then making sure that your vitamin D levels are adequate. I wouldn't recommend getting on a statin to improve your fibroid size. And then, of course, partnering with your OBGYN to discuss GnRH agonists or antagonists for potential intervention for shrinking fibroids.
Thank you. I have another question. Someone said that sex hurts for me and I've always had painful periods. Could this be related?
Absolutely. So it could be related, and one of the unifying conditions for something like that, when I just think about it off the top of my head, would be like an endometriosis. But there's also other conditions related to like the pelvic floor that can contribute to painful intercourse and even contribute to painful periods because all of those nerves are related. The pelvic floor is really dynamic, and history of chronic pain can interfere with how your nerves even kind of interpret pain or transmit pain. And so it doesn't always have to be endometriosis. That's one of the many causes, but there's a quite a list that could be the cause of painful periods and painful intercourse.
Um, there's just a comment here, well, actually, and a question as well. So,
Mhm.
ACOG recently updated their endometriosis clinical guidelines.
Yeah.
Are you heartened by this change? We had a conversation about this last
Yeah.
week. Do you think it will meaningfully impact access to diagnosis and timely treatment?
Yes, I'm heartened by this change. And so, for those who don't understand, ACOG is the American College of Obstetricians and Gynecologists. And the change ultimately said that we don't have to focus on surgical diagnosis of endometriosis. We can use clinical symptom-based diagnosis instead and start empiric treatment from that alone. My hope is that that validates people who have struggled to get a diagnosis of endometriosis and improves the clinical and diagnostic delay of endometriosis so that there's less suffering and earlier treatment for these symptoms. So I'm heartened by it. The issue, or I guess the thing that really matters, is how clinicians respond to it and that people are updated about it and that patients are also aware. If they go to a doctor that says, "Hey, we have to do surgery," you say, "Actually, no, you do not. I know that that can be diagnosed clinically and I've got all the symptoms. I'd like to start treatment." And so part of it is educating patients, and I'm hoping that more people will hear about this, so there can be meaningful change. But in short, I am heartened by it.
So am I. I think it's a really good move. It's a
Yeah.
really good movement forward. We have a few questions here about clots.
Mhm.
When are clots normal? When are they not normal? Are they a sign of heavy periods? What causes them?
So clots in
Two
and of
clots.
themselves, clots are normal in that our blood clots or sticks together. Because if our blood didn't clot, we would just bleed and bleed and bleed, and that would be really dangerous because small injuries and small cuts could lead us to lose large volumes of blood, and that could be devastating from a health standpoint. And so the presence of clots in and of itself is normal. That's what blood does. When blood gets together and hangs out long enough, it's going to stick together, and that's how, a part of a healing and protective mechanism of our body. But when we see really large blood clots, so typically we say larger than a quarter size. It doesn't mean if you have a larger than quarter size clot once that you're dying, obviously. Larger than a quarter size clot would suggest that you are bleeding fast enough and blood is collecting fast enough for it to
Mhm.
coagulate and form a clot of a larger size. And so that can be suggestive of heavier bleeding or more rapid bleeding than we like to see. So the presence of clots in and of themselves is not abnormal. The presence of clots doesn't mean that you are bleeding too much. Larger clots, clots that are really painful to pass, those get our attention because it can mean that bleeding is happening so quickly within the uterus that this collection and coagulation is able to occur, and that can be abnormal.
Right. So look at the size and how often they're happening. And
Absolutely.
yeah. Mhm. Another question. Is it still considered heavy bleeding if your period continues past 7 days? So let's say 8 or even 9 days,
Mhm.
but it's incredibly light bleeding, almost like mucus with blood mixed in.
Right. So heavy bleeding does kind of speak to the amount and the flow. And so I wouldn't say that that is considered to be heavy bleeding, but it does meet criteria for abnormal uterine bleeding. So
Mhm.
abnormal uterine bleeding is like this umbrella term, and heavy menstrual bleeding is under that umbrella because it can be that you're just bleeding too much too quickly, which is what we typically mean with heavy menstrual bleeding. There's also prolonged bleeding, and that can also lead to iron deficiency and anemia. So we care about that too. If it's lighter, it may not be as impactful, but lighter bleeding over an extended amount of days can still lead to the same outcome of iron deficiency and anemia. So the clinical picture is not just determined by how much bleeding you're doing, it's how much bleeding you're doing over what amount of time and how you respond to that clinically and how it affects your life.
Thank you. Another question about perimenopause and bleeding changes during perimenopause. Sometimes periods can get lighter. They can also
Yeah.
get much heavier as well. Any comments there? The things that you can do during
Yeah.
that stage of life?
So not a ton you can do from a improvement of that other than being on like some hormonal medicine that tries to regulate bleeding or give you a
Mhm.
more predictable pattern of bleeding. The reason that happens in perimenopause is because hormones are super volatile during that time. They rise and fall and go kind of crazy. And so heavy bleeding and unpredictable bleeding is a hallmark of perimenopause. It is as what I mean is like it's a part of an expected finding in perimenopause because hormones are changing so rapidly. It doesn't mean that you just suffer with whatever your body gives you. If you're bleeding too much, you can still be at risk for anemia. If you're bleeding too much, that can still negatively affect your life. So it's important to be in partnership with your doctor to talk about that. But those changes are a part of a physiological process of hormonal dysregulation that occurs preceding menopause, where periods will cease to occur for over at least 12 months. And once you've gone 12 months without a period, that's when you are truly postmenopausal.
And so you mentioned hormonal contraception, and this is yeah to regulate the periods and to reduce the heavy bleeding. If someone tells you that they'd rather avoid hormonal
Mhm.
options, what other options are there for heavy menstrual bleeding?
Yeah, so one of our go-to options for heavy menstrual bleeding is something called tranexamic acid. It is a medication that ultimately works in how your body clots, and so it helps your body to clot better, essentially, or blocks the lysis of clotting. And so it's called an antifibrinolytic for like fancy terms. And so that's a medicine that is not hormonal. It is not a contraceptive, and it's something that you would only take during your days of bleeding. Unfortunately, it is dosed 3 times a day for 5 days, and so it can be a cumbersome medicine to take, but it also can be something that meaningfully improves heavy menstrual bleeding without exposing you to the risk of hormonal medication.
Okay. So other options other than hormonal medications. So do not
Yeah,
despair if you don't want to take hormonal medications. There are other
correct,
options as well.
correct.
Um, we are past time, but there are so many good questions out here. So we already answered that one.
Mhm.
Let's see. Magnesium. So someone's asking this, and
Yeah.
they've been advised to take magnesium to help with heavy and painful periods. And they say it seems to make their period heavier. Is this something that's known to happen with magnesium, or is that the opposite of what's intended?
So that's the opposite of what's intended. Magnesium
Mhm.
certainly can be helpful with cramping primarily. That's what we typically see it for.
Mm.
Not so much the heaviness, but if you try something like magnesium and it is not working for you and you see worsening of your periods, please stop. It is not that we are anti-supplement or anything. This is one of the evidence-based supplements, but you need
Mhm.
to make sure that you're taking the correct magnesium, the correct dosing, and sometimes
Yeah.
our bodies don't agree with it. There are some people, like myself, I can't take NSAIDs, for example. I'm not able to because of my renal condition. There's some people who have like abnormal effects from Benadryl. And so your body will tell you whether this is a good option for you or not. It doesn't really matter what the research says. It doesn't matter what is recommended. Your body is the ultimate decision maker on whether this is helpful or not. And if it's not helpful, please don't take it.
And like you said, there are many different forms of magnesium, and
Exactly.
while they have this ultimately similar effects, their body can handle it very differently, right?
Very
So
correct.
maybe it's also a matter of trying a different formulation or stopping altogether.
Yes.
Let's see. Someone is asking about ablation, and we didn't cover this when we were
Mhm.
talking
Right.
about that, but maybe you can just comment of what endometrial ablation is used for and what option that is for.
Yeah, so endometrial ablation is an option that is used for heavy menstrual bleeding and ultimately creates a burn of the endometrial cavity. It can work really well for some people, and for other people, not so much. It's not recommended for people that are early in their reproductive years, and so we would typically say younger than like 20 or so. It just doesn't take as well in like a younger younger person. We try not to use it for people that ever desire to be pregnant again. And so the recommendation for an endometrial ablation is that you have some sort of sterilizing procedure at the same time or beforehand. So getting your tubes tied would be something that would be recommended, or even tubes removed prior to that type of procedure. And for some people it works and some people it doesn't. The saying is about a third of people really have meaningful improvement, about a third also kind of have continued heavy bleeding, and then another third might need another intervention of surgery to get true resolution of their symptoms, or even have some sort of post-surgical complication like a continued pain or chronic pain picture that requires more definitive management. So it's a good option in the tool belt, but like all of our options, it doesn't work for everyone, and your body is the decider on whether it is successful or not.
Thank you so much. And I think we have time for maybe one more question.
Okay.
I'm afraid the diagnostic test will hurt to
Mhm.
see if I have not anatomy or internal structures. Actually, you actually already answered this one. Ask for a transabdominal instead of
Right.
transvaginal ultrasound. That is one option. Is there any other
Yeah.
suggestions you can make there?
So the general guidance is from an imaging standpoint to do an ultrasound, but there's also the recommendation to do a pelvic exam because that can give us greater understanding of what's going on in the body too. Even pelvic exams can be declined, or you can talk with your provider about your fear of pain, or maybe a
Yeah.
history of a traumatic medical exam, or even sexual trauma that you've experienced. We understand that a history of trauma, either medical trauma or even sexual trauma, can inform or make these types of exams more painful. And so your provider, if they're practicing trauma-informed care, which is what I practice, I'm going to ask about your history, ask for consent, explain all of the things I want to do, and ultimately honor your decision on whether you want to proceed or not. Sometimes it takes a few visits for someone to be comfortable enough to have an exam. Sometimes you do a portion of an exam that day and we don't do the other portion. And so being really vocal about that with your provider is the best way to give them an opportunity to partner with you for diagnoses and exams that are not going to traumatize you but still lead to answers. And so if your provider is not willing to do that, I would highly recommend that you find a provider that is.
Yeah, and I think it's just super important to keep in mind that you're in charge ultimately. You don't have to do anything that you don't want to do, and having that open communication is really beneficial. But ultimately, if there's something you don't want to do, you can speak up.
Yeah,
And I
absolutely.
think that's all we have time for. I'm sorry if we didn't get to answer your question. If you do have more questions, feel free to reach out to us via my email or social media, and we'll try to answer your questions. But thank you, everyone who
Thank you,
joined and
everyone.
everyone who participated. And we hope to see you at the next Clued Up. Our next session will be happening in April, April 17th, and it is on understanding your fertility. So thank you
Awesome.
very much, everyone. Have a
Thank
great
you.
day. Bye bye.